Good morning, Pratik.
Good morning, sir.
Who all are there for presenting? You,
Good morning, sir. Myself, Vishal, sir, JR1.
Aja, Vishal, Pratik, and okay, Vaishnavi. ठीक है. Any of the gynae consultants are here?
Morning, sir. Sankita
Morning.
here.
Ankita. So I think you all can start. Last week we discussed more because we had some surgeons with us, gynae surgeons. So we discussed the nuances of different types of surgery, inconization, etc., and staging. So today for adjuvant radiotherapy and definitive radiotherapy and chemotherapy. I think chemotherapy also more emphasis will be when we'll discuss the locally advanced carcinoma cervix, but whatever part you can just mention. Okay, and you all start, and Ankita, you please continue because I have a parallel meeting. So in between, I'll just go on that.
Sure.
I may or may not sort of come back to this. So I'm
Sure.
listening, but okay, carry on.
Good morning, everybody. Myself, Dr. Vishal. I am JR1. We will be presenting today's ward round. The topic of today's ward round is role of radiation in early cervical cancer. So we will start with the case. So we have a case of a 68-year-old female. She is from Uttar Pradesh. She is a homemaker. She presented with complaint of intermittent abdominal distension since last 4 to 5 years. History of present illness. She was apparently all right 5 years back. Then she developed intermittent abdominal distension, which is gradual in progression and not associated with pain. Coming to negative history, she had no history of burning menstruation or urinary urgency or hematuria. She had no history of altered bowel habits, no history of vaginal or rectal bleeding, no history of vaginal discharge, no history of dyspnea and bone pain, and she also had no history of any headache, vomiting, or convulsions. Uh, Past history, she had no history of comorbidities like hypertension, diabetes, asthma, or tuberculosis. She had no previous history of any surgery, and she never used OCPs. Family history, she had no significant family history of malignancy. Personal history, she denies addiction. Her appetite is normal, and bowel bladder habits are normal. Sleep cycle is not disturbed. Coming to obstetric history, she is a postmenopausal since last 7 years. She attained menarche at age of 14 years and menopause at age of 61 years. So her age at marriage was 22 years and age at first childbirth was 22 years. So she is a para food living 4 and abortion 0. All deliveries are normal vaginal delivery and she breastfed all children for around 6 to 8 months and tubal ligation were not done. Socioeconomic history, she lives in a Pakka house. She has access to a municipality water supply. There are 5 members in family. She lives with her husband, second son and his wife, and one grandson. The education of the head of family, which is her second son, is a high school. Her second son is a daily wage worker and monthly income of around 15,000 he earns. So Kukuswami's score was around 11, so she belongs to lower middle class. On general examination, patient was explained about the procedure, verbal consent was taken, and examination was done in well-illuminated room with adequate privacy and presence of female attendants. Her general condition was good with KPS 90 on temperature was febrile on touch, pulse was 85 beats per minute, respiratory rate was 15 per minute, blood pressure was of 130 by 80 mmHg, no pallor icterus, cyanosis, clubbing or edema, and there is no palpable lymphadenopathy. Systemic examination, she is conscious oriented to time place person. The higher function motors are intact. The cerebral signs are okay. On severe, the S1 S2 heard. There are no murmurs heard. Respiratory system bilateral air entry is equal on both sides. Perabdominal soft non-tender, no palpable organomegaly. And bilateral waist was normal, no palpable mass. Coming to local examination, on inspection, there is no abdominal distension, no visible abdominal mass, no visible growth or abnormality was seen at external genitalia, no pervaginal discharge seen, no visible inguinal nerves. On pervaginal bimanual perrectal examination, there is a 3 into 3 centimeter proliferative lesion involving both lips of the cervix. All furnaces are free. Bilateral para was free. Vaginal mucosa and rectal mucosa are free. There are no palpable inguinal nodes. On per-abdominal examination, it is soft, non-tender, and no organomegaly. Coming to investigations, the UVA and vaginal mapping was done. On vaginal mapping with Lugol iodine, there is a uniform uptick in all the vaginal mucosa. On per speculum examination, 2 centimeter proliferative lesion in the cervix. Vaginal fornices are free. Bilateral para and rectal mucosa was free. Coming to MRI, on MRI, there is a T2 intermediate soft tissue mass is seen in posterior lateral wall of the cervix, which measures of 2.5 into 1.6 into 1.8 centimeter, extending into vaginal fornices, or vaginal fornix with effacement of the posterior vaginal fornix. Parameter is not involved, the urinary bladder and the rectum are not involved. Uterus is unremarkable, there is no adnexal mass and no suspicious adenopathy. So these are the MRI images. You can see it's a T2 hyperintense lesion. So on biopsy, it's a poorly differentiated squamous cell carcinoma with P16 positivity. On CT thorax, there are no suspicious lung nodules. So it's coming to the impression. So this is the case of CS cervix stage 1B2. And the further treatment plan was like patient was planned for radical hysterectomy plus bilateral salpingo-oophorectomy plus bilateral pelvic node dissection followed by adjuvant arterial pelvis and followed by vaginal brachytherapy. So the treatment given was patient was underwent type 3 nerve sparing radical hysterectomy plus bilateral salpingo-oophorectomy plus bilateral pelvic lymph node dissection on 19th April 2023. On its histopathological report was.
Vishal, can you go back?
Yes, ma'am.
Right. So your treatment plan in this case would not include radical hysterectomy surgery followed by adjuvant RT followed by vaginal brachytherapy, because adjuvant RT and vaginal brachytherapy in this case will be given if and when indicated. Okay. So your treatment plan in the first go, like after your history and examination, and once you got the diagnosis, would be surgery. Okay. So you have to tell us like the patient was planned for surgery based on what all features, and then after surgery what the post-op histopath showed, and then we plan the patient for adjuvant RT if and when it was indicated. Okay.
Yes. Okay.
So your
Okay.
treatment
So
plan is hysterectomy
yes,
followed by RT. Okay.
Yes, ma'am. Yes, ma'am. Patient was planned for hysterectomy. Then patient underwent surgery on 19th April 23. The HPR it's a poorly differentiated squamous cell carcinoma with tumor size of 2.7 into 1.8 into 0.9 centimeter. It's a deep stromal imaging was present, and stromal inflammation was also seen. Bilateral para are free. The LV size present. All margins are free with closest cut margin is of 1.5 centimeter. So there are 21 lymph nodes dissected, out of which all are negative for metastasis. So it's a poorly differentiated stage 1B2 squamous cell carcinoma with deep stromal invasion and positive LVSI. So patient was planned for adjuvant TBRT.
Go back, Michelle.
Yes, ma'am.
What were the intra-op findings? So you also have to, in every case which has been operated, the intra-op findings need to be noted and they need to be considered whenever we plan adjuvant treatment.
Okay.
Okay, you should include the intra-op findings here.
Okay, ma'am. So she received adjuvant RT to pelvis to a dose of 45 gray in 25 fractions using rapid act technique with 6 ME photon energy from 24th July 23 30th August 23. The radiation was tolerated well. Post RT acute toxicity was skin grade 1 and GIJS was grade 1. So these are the portals of treatment. And coming to this is the 95% dose was of the treatment. And this is the 90% dose was. So
Can I ask you if she could have done with the less surgery? Of course, the surgery of choice, you have written the choice of surgery, right? Radical hysterectomy and bilateral pelvic lymph node dissection. She had just a 2.7 centimeter tumor. Would less intense surgery, because what you're describing is a type 3 radical hysterectomy for her. Could she have managed with lesser surgery, like type 2? Indirectly, I'm asking you that what is the evidence supporting radical hysterectomy for her?
Ma'am, the recent FIGO 2021 guidelines, they recommend simple type A, which is the simple extrafacial hysterectomy only for stage 1A1 without LVSI. And type B hysterectomy, that is a modified radical hysterectomy, is recommended for stage 1A with LVSI or stage 1A2. And ma'am, for stage 1B1, 1B2, and for selected patients of stage 2A, type 3 radical hysterectomy is recommended.
Can you please identify yourself? Sorry, I could not make out who's speaking.
Ma'am, Vaishnavi.
Vaishnavi, the reason I've asked this question is because in 2023, we have a new randomized trial called as SHAPE trial from surgery, right? And in that, tumors which are 2 centimeter or less, they have equivalent outcome with a less intensive surgery. And I think all of you should be aware, for this patient, radical hysterectomy is perfect because it's 2 or more. But in a tumor that is smaller, all of you should be aware, it's a major trial that has come out in 2023. And guidelines are yet to be updated. It's for your information.
Okay, ma'am.
She received vaginal brachytherapy to a dose of 6 gray in 2 fractions with 3 centimeter cylinders used from 24th July 23 to 30th August 23. The OTT is of 67 days. So equilibrium dosage of the bladder received 71 gray, the rectum received 64.5 gray, the sigmoid received 53.5 gray, and bowel received 50 gray. From
Go back, Vishal. Go back. So
Yes,
here,
ma'am.
what are you missing? Vaishnavi, can you explain what all is missing here? What is the depth of prescription? What is the length that we were treating?
Ma'am, so she was prescribed 2.5 centimeter below the surface of the cylinder, like the point at which we are prescribing, that should have been mentioned here. And the vaginal length that we have treated, ma'am.
So you need to mention the vaginal length that was treated. How much vaginal length was treated here? Okay, you need to check that. And what about the overall treatment time? Why was the overall treatment time 67 days? Were there any reasons, or it is normal? Is an overall treatment time of 67 days normal for a patient of CA cervix if she receives adjuvant RT and vaginal brachytherapy?
No, ma'am, actually the patient should be completing treatment within 50 days.
No, so why was this patient treated over 67 days? You need to go back and see. Okay.
Also go back, just go back on EBRT slides also. EBRT slides. Yeah. So in this slide also, you have not described technique. That is missing, right? And then you go back again to, yeah, 3D CRT, 2D, APPA, IMRT. It's not mentioned here. And then
target volume, to mention the target volume.
And also for brachy, go back to organ at risk doses. So here there is no mention. It is to which volume of bladder, rectum, sigmoid, and bowel. 2 cc is missing here. One more question for all students. None of the clinical trials, like from where post-op RT comes, like Sedlis or Rotman, or even Peter's trial, nowhere brachy. It's only EBRT 45 gray. Do you think we are doing something wrong in Tata by adding brachy?
Ma'am, regarding brachytherapy, we've actually added in
Not you,
the
Vaishnavi.
part.
Not.
Okay.
Okay. Sorry, please go ahead.
I think students last week also, it was said that when you describe external beam, you explain the technique, the portals. Without that, it doesn't mean anything. So, and Supriya rightly caught you all and asked you that. So please, there's some basic things you have to always tell when you are describing something. Okay.
Sir,
think there's some I think there's some problem with the connection.
yes, ma'am, it got disconnected. We are just trying to.
I think you all got logged out probably. So, is someone able to sort it out? What's happening?
So just 2 minutes. We're just trying to get the Wi-Fi connection. Just 2 minutes.
Okay, okay.
Hello. Are the slides visible?
Yes, slides are visible. Make full screen.
Sorry for the inconvenience. So should we proceed?
Yeah, please carry on.
So as we last week we have discussed about the surgery role in early cervical cancer. Now we will discuss about the role of adjuvant radiation in early cervical cancers. In early stage cervical cancer, there will be 1A1, 1A2, 1B1, 1B2 and 2A1 according to the FIGO staging 2018. So 1A1 is the stromal invasion less than or equal to 3 mm in depth. 1A2 is the stromal invasion more than 3 and less than or equal to 5 mm in depth. 1B1 is the stromal invasion more than 5 mm, but the lesion of size should be less than or equal to 2 centimeter in greatest dimension. 1B2 is invasive carcinoma more than 2 and less than or equal to 4 centimeter in greatest dimension. And 2A1 is less than or equal to 4 centimeter in greatest dimension with upper two-third of vaginal wall involvement. So the treatment modality for early cervical cancers are surgery and radiotherapy. So for stage 1A1 and 1A2, the treatment modality will depend on the lymphovascular uh, stromal invasion. If LVSI is negative in T1A, uh, there is no need of lymph node staging. So we can consider for colonization as a definitive treatment. But if in 1A1 LVSI is positive, then we will go ahead with the sentinel lymph node biopsy and colonization as
Pratik,
definitive.
can I please interrupt you? Please do not follow these ESCO guidelines. They're absolutely non-validated for surgical endpoints. The clinical trials which have just started have made to guidelines, and we have communicated with them multiple times. Can you please refer to NCG guidelines when you're speaking about cervix cancer?
Okay, ma'am.
Yeah, because there are some of their clinical trials, they are still going on. And one of their major surgeons, David Chibula, he starts trials and he puts the test arm as part of guidelines. And this is heavily criticized, at least by all of us very openly. No one follows like this here, right? Abhi ke liye you can go on, but for your exams and clinical practice, please refer to NCG guidelines.
Yes, ma'am. Sure.
Yeah, thank you.
Thank you. For 1A2, if LVSI is negative, then sentinel lymph node biopsy is considered, and colonization or simple hysterectomy is the adequate treatment. If LVSI is positive, then sentinel lymph node biopsy should be performed, and the colonization or simple hysterectomy is an adequate treatment. So for stage 1B1, 1B2, and 2A1, it depends on the lymph node positivity. If lymph node is positive, then it will go directly for definitive CTRT with image guided brachytherapy. But if
Biopsy and other,
sorry, ma'am.
not, still into our clinical practice. But
Uh, sorry, ma'am.
see, these workflows now, they are not in practice in India in general, right? Abhi, yeah, I think I missed part of, transition of slides. Sorry, you can tell you when up.
Okay, ma'am. Should I go ahead with the slides?
Yes, yes, Pratik, go on.
If lymph nodes are negative, then we'll go ahead with the surgery. During surgery, if on lymph node biopsy, the lymph node, if it came out to be positive, then we will avoid further lymph node dissection and avoid the hysterectomy and go ahead with the definitive CTRTA with plus with the image guided brachytherapy. If lymph node came out to be negative during the surgery, then we'll go ahead with the hysterectomy. So this is a randomized trial by Landoni et al. Studied radical surgery versus radiation for stage 1B and 2A. They accrued 343 patients divided into two arms, radiotherapy arm and radical hysterectomy plus adjuvant RT arm. So the result came out to be 5 years survival, overall survival and disease-free survival, and recurrence rates were almost similar, with worse morbidity in the adjuvant RT group. So The interpretation of the study was if clinical factors should be considered for optimal therapy, such as menopausal status, age, medical illness, histological type, and cervical diameter to yield the best cure with minimum complications. So these are the indications for post-op radiotherapy.
Pratik, I'll stop you again here. Just 1
Yes,
second.
ma'am.
There is a 20-year follow-up of Landini trial published. Actually, the worst outcomes there are in surgery alone arm. Do you have that update slide? It's published in 2017, Landini's trial.
No, ma'am, we have not added that slide in
Can you please update everyone later?
Yes,
Because
ma'am,
it's a
sure.
20-year follow-up.
Mhm. Indications for post-op radiotherapy are if there is no risk factors, so no further treatment is required. But in intermediate risk, if the stromal invasion is more than two-thirds, and if capillary lymphatic space is involved and size of tumor is more than or equal to 4 centimeter, according to the set list criteria, any two of these intermediate risk requires adjoint RT. And in the high risk group, if there is a positive lymph node, positive parametrium, and positive surgical margin. So according to the Peters criteria, any one of this high risk feature is present, then it will need adjoint CTRT. This is the trial by Steadley's randomized trial of pelvic radiation therapy versus no further therapy. They accrued 277 patients with stage 1B disease, post-op case, and lymph node negative, with a inclusion criteria of more than one-third stromal invasion, LVSI involvement, and tumor size more than or equal to 4 centimeter. So they have divided patients in two arms. First one is a post-op radiotherapy arm and no further treatment arm. So in radiotherapy arm, they received 50.4 play in 46 to 50.4 play in 23 to 28 fractions, but no brachytherapy was given. So the recurrence-free rate at 2 years in post-RT arm was 88%, and in no further treatment arm was 79%. So the conclusion of the study was it has statistically significant reduction in recurrence risk of recurrence with 6% of grade 3 and 4 adverse toxicity in post-adjuvant material. But there was some limitations for Sedley's trial. The histological factor was 78% of patients had squamous cell carcinoma and 23 had non-squamous cell types, which was included adenocarcinoma, which was more aggressive in nature. The FIGO staging, the Sedleys include only one way patient with size of less than 2 centimeter, more than 6 centimeter. But it was not divided in 1B1, 1B2, 1B3 according to the FIGO staging 2019. And they have not mentioned the radical surgery characteristics in the paper. And the radiation technique was used four field technique. This is a paper by Peters et al. On concurrent chemotherapy and pelvic radiotherapy compared with on pelvic radiation therapy alone in high risk of early stage cervical cancers. So they accrued 243 patients. The purpose of study was to see whether addition of cisplatin-based chemotherapy to pelvic RT will improve the survival of early stage high risk patient with cervical cancer or not. They have divided patients in two arms, post-RT arm and post-CTRT, post-op CTRT arm.
Pratik, one
yes.
question to all of you. Setlist criteria is in early stage cervical cancer, node negative. So here you've shown 88% local control with surgery plus adjuvant RT. In similar stage, what are the outcomes of chemoradiotherapy for local control now? So, for example, if we decide to treat patient with definitive CTRT 1B2, modern 1B2, right? So, or 2A1. So, what is the local control you expect? Anyone can answer from students.
Ma'am, more than 95%.
I think, yes. So, it's around 96 to 98%.
Yes, ma'am.
Of course, you cannot compare directly. So, now more and more patients, like in 1 year, in Tata Hospital, less than 25 cancer. Please.
Okay. Ma'am, should I proceed?
Yeah, please.
Yes.
Uh, Peter Sackler accrued 243 patients to see whether addition of cisplatin-based chemotherapy to pelvic RT will improve survival of early stage high-risk patients. So they have divided patients into two arms, post-RT arm and post-op CT-RT arm. So in CT-RT arm, they have given 2 cycles of cisplatin with fluorouracil, and they are seeing the progression-free survival. So progression-free survival in post-RT arm was 63% as compared to CT-RT arm 80%, and overall survival difference was also almost 10%. So the conclusion of paper was the progression-free survival and overall survival significantly improved in patients after receiving the concurrent chemotherapy with acceptable GI and hematological toxicities. So this is a trial by Dr. Sudhir Gupta sir from our institute. It compared neoadjuvant chemotherapy followed by
Just one question on Peter's trial.
yes, ma'am.
Peter's trial had concurrent and adjuvant chemotherapy, right?
Yes,
Two
ma'am.
cycles
2 cycles
concurrent, two
were
cycle
given
adjuvant.
in concurrent therapy and 2 cycles in adjuvant therapy.
Why don't we do adjuvant? We just give single agent platinum in our clinical practice. Why are we not following that standard of care, right, in Peter's trial?
Sorry, ma'am.
Anyone can answer. See, my question is that this trial created evidence for 2 cycles of cisplatin 5U concurrent and followed by 2 more cycles adjuvant.
Yes.
But what the entire world does is just 5 cycles concurrent. So why that was adopted? And before even you show Dr. Sudeep Gupta's trial, so last has come, which has resolved the in post-op setting concurrent and adjuvant problems.
Sorry, I'm not sure about it.
Anyone can answer. Any other students, please?
Ma'am,
Yeah, please, Vaishnavi, please go on.
yeah, ma'am. So this was conducted in, like, this trial was conducted in the 1990s and it was published in the year 2000, when simultaneously there were 5 major randomized controlled trials which were exploring the role of concurrent chemotherapy with radiotherapy in both locally advanced as well as in the adjuvant setting for CA cervix. And once these 5 randomized trials were published, they established the role of concurrent chemoradiotherapy with cisplatin-based chemotherapy. as the standard of care in CA cervix patients. And ma'am, regarding the adjuvant part that you were asking, uh, it was the Outback
No, Outback is locally advanced.
locally advanced. Yes, ma'am. But in like post-op setting, I'm not sure of the evidence that we have for
It's
adjuvant CTRT followed by adjuvant chemo.
See, for this trial, because they used both concurrent and adjuvant, it was
Hmm.
never clear that from where the benefit is coming, concurrent part or adjuvant part. And generally, after pelvic radiotherapy, these treatments are quite substantial for patients to tolerate. So the
Yes, ma'am.
trial that has been done and completed and presented last year is RTOG 724, in which
Okay.
patients were randomized to receive only concurrent CTRT versus concurrent plus adjuvant. It was
Okay.
presented last year and it's a negative trial. But people for last 15 years never adopted the adjuvant part because of lack of understanding that what is actually benefiting the patient. So in a very odd way, only concurrent part was adopted and adjuvant part was discarded for all these years. And now we
Okay.
know for good reasons that final trial is also negative. Yeah,
Hmm.
thank you.
So this trial by Dr. Sudhir Gupta sir compared neoadjuvant chemotherapy followed by radical surgery versus concomitant chemotherapy, chemoradiation in patients with stage 1B2, 2A, or 2B squamous cervical cancers. So the patient record was 635 in 2 arms, LACT followed by radical hysterectomy and concomitant CTRT with weekly cisplatin. It resulted into 5 year disease-free survival was 69% in NSAT followed by surgery group and 76% in CTRT group. And overall survival was almost similar. Concomitant chemoradiotherapy resulting superior disease-free survival compared with the NSAT group in locally advanced cervical cancer.
What was the
So this
hypothesis of this study? What was the primary hypothesis of the study of neoadjuvant trial? And
ma'am, to
it was not in early stage. So this slide should not come in early stage cancer. It was in old FIGO 1B2. That means tumors more than 4 centimeter or 2B. So this is a locally advanced trial. It's not an early stage trial.
yes, ma'am.
So what was the primary hypothesis of this trial?
Ma'am, to downstage the disease.
अरे primary hypothesis, primary endpoint क्या था? What did the trial want to prove?
Primary
See, the trial hypothesis was that neoadjuvant chemo plus surgery will be 10% superior, and it turned out exactly the opposite.
yes, ma'am.
And which is the other trial apart from NACT? अरे old slides present कर रहे हो 2 साल पहले एक और trial भी आया है ना neoadjuvant का. Where is that slide?
Ma'am,
Where is the URTC study?
no, ma'am, we have not added
Hmm?
that slide.
क्यों नहीं डाला है? तो 2 साल हो गए ट्रायल को आए हुए. Anyone else? Anyone can speak about URTC? Any resident can please update URTC trial? I will just say it. It is also a 700, 600 patient trial. Again, similar randomization led by the European group. It was also designed almost same primary hypothesis. It's just that they used OS as the endpoint. And in that also, it was exactly the reverse. That the primary hypothesis was that neoadjuvant chemo plus surgery will be superior to CTRT, but the final conclusions were exactly the opposite. So please read that trial and put it in. These are the two major trials, and they will become more and more relevant because this year interlace is also coming. It's already presented 2 years ago, and neoadjuvant is again making a comeback with interlace. Yeah, thank you.
Yes, ma'am. Thank you. So this is an energy RTOG 1203 trial by Anne Clough. They designed phase 3 randomized control trial to compare patient-reported acute GI toxicities and the quality of life during the treatment with pelvic RT and this called IMRT. So they enrolled 278 patients and given 45 gray or 50.4 gray based on physical preferences with concurrent disability weekly. The conclusion of the paper was the pelvic MRT was associated with significantly less toxicities than the standard RT, which was forceful.
Pratik, again, this information is not clear. Go back.
Yes,
RTOG 1203 has 85% patients of endometrial cancer. How can you write that patients received 5 cycles of concurrent platinum? उसमें सिर्फ 15% cervix cancer है. Vast majority of patients have received RT alone. ये किधर से slides लेके आए हो तुम? And the update of the study is no difference in late toxicity 1203 का. 2020 update is there, then I think उसके बाद भी is another paper. This is an endometrial cancer study with 15% cervix cancer. But anyway, go on to the next slides. It's fine.
So, this is a trial from our institute by Supriya ma'am. The phase 3 randomized trial of post-adjuvant radiation therapy comparing the 3D CRT versus IMRT in cervical cancer. I include 300 patients was planned for post-adjuvant radiotherapy and complete the late toxicities in the 3D CRT and IMRT arm. So the primary endpoint of the study was to see the incidence of more than grade 2 bowel toxicities. So the result came out to be the three either grade more than 2 late toxicities was 21% in ITM, IMRT arm and 42% in KDCRT arm, which was statistically significant. This graph showing on the x-axis time since randomized assignment with on the y-axis the rate of two toxicities. So the blue line shows KDCRT and the red line shows IGMT, which was statistically significant difference in two toxicities. And the B image showing the grade 3 GI toxicities. MRT results in reduced toxicity with no difference in the disease outcomes. This is a paper by Dr. Prachi Mittal on the patterns of relapse after adjuvant chemoradiation for cervical cancer in phase 3 clinical trials. So, this study was designed to evaluate the implication of newly published guidelines. So, we have randomized 300 patients adjuvant CGRT in cervical cancers to understand the pattern of relapse. In this study, what we actually did was we have imported structure sets and treatment plan and diagnostic CT. Diagnostic CT, actually, relapse was there in the TPS, and then we delineated the GTV over the diagnostic CT and superimposed on the radiation treatment scan that was previously done. So the relapse within the field of the patient's personal delineation guidelines and the NRG RTOG guidelines are compared. So, the pelvic relapse rate was overall 8%, out of which 9 relapse was in the faster contouring guidelines and 12 relapse was in the energy RTOG 2021 guidelines. So it corresponds to for the 1% reduction in local readings, and there was no difference in the world. So it has been concluded the use of newly published energy RTOG guidelines uh, uh, with the further data to ascertain if anti-age extension of the CTV is needed as a course of adjuvant radiation therapy. So these were the partial contouring guidelines in which we have put a vaginal vault marker to identify the cranial limit of the vault, and radiation planning scan taken with full and empty bladder uh, with 3 CCD cuts. In contouring part, all target delineation is done prior to the randomization. The structure contour was vagina with empty bladder, vagina with full bladder, and the CTV is contoured on both empty and full bladder. Uh, the cranial limit was 1 centimeter superior to the CTV full bladder and empty bladder. The medial extent was the pelvic muscles. Inferiorly, half of the vaginal length. Anteriorly, it was expanded 1 to 1.5 centimeter anterior and will not be irritated from oil and bladder. And posteriorly, it extends to the mesorectal fascia. Then ATV is generated.
We can't hear you.
Pelvic vessels to create the CTV node, and the PTV is created by giving 5 minutes expansion to the CTV node. So these are the NRG RTOG contouring guidelines by William.
You can skip this.
Oh. So these were the two differences
And again,
in contouring.
because this was endometrium, right?
Yes. So this is a trial by one on post-operative hypofractionated IMRT on cervical cancer. This was a phase 2 study to evaluate the toxicities of hypofractionated IMRT. The inclusion criteria of the study was tumor size more than or equal to 4 centimeter, LBSI positive, and invasion depth more than half of the cervical stroma. So the result came to be this in terms of CTV delineation, there were differences between the different institutes. So the consensus CTV was generated from this study. This is the same study with the use of concurrent chemotherapy with hypofractionated IMRT arm. So it was non-randomized trial by Won-Chu in April 2024. It was multi-center phase 2 trial. The study evaluated the acute toxicities of hypofractionated pelvic IMRT arm with concurrent chemo in post-op cervical cancers. There was only 2 patients with a grade 3 toxicities. Uh, so post-op pelvic IMRT with concurrent chemo was safe and well tolerated in this study. Role of brachytherapy will be explained by
Pratik, can you go back and can you summarize everything about adjuvant RT, adjuvant EBRT in CA cervix? So what is so you've shown us the evidence. What is the what are the indications of post-op RT and post-op CCRT in CA cervix? What are the
Yes.
targets? So can you once again explain? So you this is what you've told is the target volumes that PASA used and NRG used. What is the target volume that we need to include in a patient of CA cervix for adjuvant RT? What is the nodal target volume and what is the primary target volume? Can you please summarize in 2 minutes?
Yes, ma'am. In nodal target volume, we will include the common iliac nodes
Will be
then
the upper border.
sorry,
What will you start contouring the common iliac nodes from where? What is the upper border?
from ma'am, L4 as L5 will contour from
L4, L5, what?
uh,
You contour it from superior border starts from
superior border.
okay. So you
Yes,
start the L4, N5 interspace. You contour the
okay.
common iliac vessels. What else? What are your target volumes? Other target volumes? Which nodes would you include?
I'll include the common iliac nodes, including external and internal iliac nodes.
What
Then,
else?
obturator nodes and presacral nodes.
Okay. And what is the primary target volume here?
Primary target volume will be the post-op cervical bed,
The post-op tumor bed or
tumor
what?
bed, and, the vaginal with vagina up, upper two-third.
Okay. What else? So what else do you contour here? Your target volume would include nodal, as you said, and your primary target volume would include the vagina, the post-op tumor bed, the upper two-thirds of the vagina. Okay. So
Yes.
yes. So and then what else? What else apart from the vagina? You already told that. How much do we take anteriorly? How much do we take posteriorly? What do we include?
1 to 1.5 centimeter anteriorly to the posterior wall of bladder.
It's 1 centimeter. You can say 1 centimeter. And what about posterior?
Posteriorly, ma'am, up to the mesorectal fascia.
Okay, so you spoke about this trial with the pattern that showed the patterns of relapse in PASA trial. What did it show, and what did we eventually change in our contouring practice after this after this study, the patterns of relapse? So what do we
So, ma'am,
really?
pattern of relapse, we have detected 9 patient relapse by the guidelines we have used in PASSER. And if we use the new RTOG guidelines, we have seen that 12 patients got relapse. So,
That is okay. So what we do is we include, so if in a patient of CS cervix post-op, we include the anterior 1/3 of the mesorectum as well. Okay. So whenever
okay.
we used to include only up to the mesorectal fascia, now we include the anterior 1/3 of the mesorectum in the CTV primary, CTV tumor post-op
Okay.
bed. That's the major change we do.
Yes.
Because our references, those patients mostly record in the mesorectal space. Okay. Oh yeah,
Yes,
go ahead with brachytherapy. Make it quick.
Brachytherapy has a role in early stage CA cervix post hysterectomy as an adjunct to EBRT plus minus chemotherapy, or it can be used as an alternate to surgery in medically inoperable patients or patients who are not willing for surgery plus minus EBRT. So as ma'am already mentioned, what the need is for post-op brachytherapy. So GOG 92 and 109 were the major randomized control trials which established the role of adjuvant EBRT and adjuvant CTRT in patients with intermediate risk factors and high risk factors respectively. However, notably the local recurrences in the RT arm were 13.1% in the SEDLES trial, whereas 7 out of 20 recurrences in the CTRT arm were also local recurrences. Also in the RT alone arm, the local / pelvic recurrences were 14%, and in the CTRT arm, it was 8% in the Peters trial. So the local failure rate was still higher than what should be ideal. So that's why it was postulated that there was still scope for dose escalation with adjuvant EBRT, and brachytherapy was not given in both of these trials. So this is the NCDB database of over 115,000 patients diagnosed with CA cervix from 2004 to 2015. They did a retrospective analysis of over 1,700 patients who underwent hysterectomy and they had positive surgical margins. And all these patients received adjuvant RT, which was either EBRT alone or EBRT followed by brachytherapy boost. So in this study, about 45.3% of patients received brachytherapy and rest of the patients received EBRT alone. The predictors of increased receipt of brachytherapy were age more than 55 years, patients with private insurance, overall treatment time more than 7 weeks, EBRT dose of more than 45 gray, and the time between RT and surgery when it was less than 9 weeks. At a median follow-up of 3.8 years, there was a statistically significant increase in 3-year overall survival of about 8% with the addition of brachytherapy to EBRT, and these results were also upheld on the multivariate analysis. Then this is another retrospective study which studied the impact of treatment policy changes in early stage CA cervix treated with adjuvant chemoradiotherapy. So they retrospectively analyzed 292 patients who were treated between 1970 to 2007. All these patients received adjuvant EBRT to a dose of 40 to 46 gray at 1.8 to 2 gray per fraction after radical hysterectomy. So as part of the institutional protocol, VBT was added since 1993 for patients who had high-risk factors, that is, they were CA adenocarcinoma, along with either nodal involvement or parametrial invasion. So on multivariate analysis, they revealed that histology of adeno-CA, lymph node metastasis, and para-involvement were significant prognostic factors for loco-regional control. So they showed that adeno-CA has poorer loco-regional control as compared to squamous histology. But one of the significant findings of this study was that this influence of histology on local control disappeared after systematic application of vaginal wall brachytherapy for patients with adenocarcinoma of cervix since 1993. This is another retrospective analysis of the impact of brachytherapy boost and EBRT dose escalation on overall survival in early CA cervix from the NCDB database again. 630 patients who were diagnosed with squamous or adeno-CA of cervix who had positive margins following hysterectomy received post-op chemoradiotherapy. 53% patients received EBRT alone and 47% patients received EBRT plus brachytherapy boost. In this study also, they showed improvement in overall survival with EBRT and brachytherapy boost versus EBRT alone. And notably, EBRT dose escalation more than 50.4 gray was not found to be associated with overall survival. So this is a retrospective analysis by the Turkish Society for Radiation Oncology group,
Yes,
in which
you can just summarize all these studies. You don't need to go
yes,
through all
ma'am.
studies.
Okay, ma'am. So in this study actually had contradicting results. However, it was a retrospective analysis of 480 patients in which they said that adding VBT boost to EBRT did not provide any benefit in local control or survival. However, we have randomized data from our own institute, PARSER, which was a phase 3 RCT, or as already mentioned, the primary endpoint was late toxicity, and it was shown that there was improvement in cumulative incidence of any grade, more than grade 2, any late toxicity, as well as more than grade 2 late GI toxicities, along with reduction in patient-related outcomes. Although there was no no difference in both the arms in any of the disease outcomes. Notably, in this study, the pelvic relapse was 4.6%, which is lower than that observed in the previous trials. Like in the Sedley's trial, it was 14%. And in the CTRT arm of Peter's trial, it was 8%. The addition of brachytherapy in our patients, since all the patients in PARSER received 50 grain 25 fractions followed by VBT, 6 grain 2 fractions. So it is postulated that brachytherapy may be needed over and above chemoradiation to improve the in-field local control. So currently the NCD of India consensus guidelines state that EBRT to a dose of 45 to 46 gray in 23 to 25 fractions should be given in the post-op setting, and additional brachytherapy is recommended in patients with involved vaginal margins or with suboptimal removal of the vaginal cuff. The target volume for brachytherapy is the upper third of the residual vagina, but in no case it should be more than 4 centimeters. 6 grain.
These are the guidelines, but what we discussed in the previous slide, all patients with CA cervix during adjuvant RT, after adjuvant EBRT, they receive vaginal brachytherapy, okay? 6 gray into 2 fractions.
Yes, ma'am. Yeah. The prescription is 6 gray to 2 fractions. It's prescribed at 5 mm from the vaginal cylinder surface 1 week apart. And the entire treatment should be completed within 8 weeks. And in case of suboptimal surgery, adjuvant CTRT followed by vaginal brachytherapy is the treatment of choice. So brachytherapy as an alternative to surgery in early CA cervix.
Vaishnavi,
Sorry, ma'am.
I just wanted to clarify on what Ankita has said. Here we had
Yes.
used the word may because parser data came in 2020, because we were also looking at that time that no one in the world does brachy after EBRT. And if we don't see excessive relapses, we will also drop brachy. So we had
Yes.
used a softer language in guidelines because
Yes,
we were
ma'am.
not sure of our outcomes then.
Hmm.
Yeah, thank you.
Yes. So brachytherapy as an alternative to surgery in early CA cervix can be considered in patients who are medically inoperable or those who are not willing for surgery.
I think, excuse me, I think the time is over. So radical brachy we can cover later, maybe next week.
So just 3 slides.
Okay.
Yes.
Carry on.
So in a retrospective analysis, which was published in the 1990s, it was shown that ICA alone is an excellent treatment option for patients with medically inoperable stage 1A and CIS of the cervix. Recently, brachytherapy has also been explored in the pre-op setting, where they have shown a complete pathological response post-hysterectomy of 75.4% with patients who have received brachytherapy before hysterectomy. And this is where the guidelines currently stand. For stage 1A1 medically inoperable, radical brachytherapy alone up to a dose of 65 gray EQT2 to 0.8 is also an option. And for stage 1A2, brachy alone or EBRT and brachytherapy up to 70 gray to 0.8 can be used. And as per the FIGO 2021 update, patients with microinvasive disease who are treated with ICA alone also have good results if surgery is contraindicated. And selected patients with stage 1B1 may also be treated with ICRT alone to a dose of 60 to 65 gray equivalent prescribed to 0.8. Thank you, sir. Thank you.
So thank you. I think you all residents should realize that Dr. Supriya and Dr. Ankita brought out many deficiencies in your presentation, old slides or covering other aspects. So please put up your revised PPT. Again, we will share it. I won't ask for a repeat presentation. So Supriya, for early stage cervical cancer, what is remaining, or we have covered everything?
I think, sir, more or less everything is covered.
Yeah.
And one slide that was missing was that in young women, we would definitely consider ovarian transposition.
Yeah,
So
that's
that is
very
a major
important.
thing. Yeah.
Because quality of life issues and survivorship issues are important. Okay, then I think thank you. Next week we will cover who's a set of residents presenting next week on locally advanced cervix, stage 2B and 3.
So I think Shejin is there
Okay.
from Pratik's batch.
Okay. Okay, then. Thank you.
Thank you, sir. Thank you, ma'am.
Any other comments, Supriya, you or Ankita would like to make? Or?
No, sir. Thank you.
Thank you. Thank you.